afternoon, everyone, and welcome to our webinar today, brought to you by PhysiQuip. So we specialize in MSK rehab solutions, diagnostic ultrasound, shockwave therapy, and force plates. And we have a large focus on education and providing helpful resources to clinicians like this one today. So we're delighted to be joined by Dr. Jamie Kearns, who will be presenting on real-life ultrasound scenarios, showcasing its effectiveness in MSK diagnostics. So Jamie is a vastly experienced sports and exercise medicine consultant and is head of medical at Munster Rugby. The format of the webinar will be a presentation followed by a Q&A. And for those of you who have joined the session live, if you have any questions, please submit these in the Q&A tab. I will now hand over to Jamie for an introduction and then on to the presentation. Thanks, Jamie.
Thanks very much, Jamie, and thank you to Andy and Katie for inviting me to talk today. So the remit I was given was maybe to look at maybe some case studies of how I use ultrasound in my daily practice, both across the professional rugby sphere and also then in my day-to-day practice as a sports and exercise medicine consultant. So the cases I'm going to show today are all real-life cases. They're all anonymous. And just to give a flavor of how I'd use ultrasound on a kind of fairly regular basis. So just in brief, just to give a background, my own journey is that I would have originally trained in UCD in Dublin, that's Earlsfort Terrace. I would have then moved to Galway, having completed my medical training. And if anyone knows Galway, it is wet and wild and rainy all the time. So I worked at University Hospital Galway as a medical trainee, and then would have spent some time in America in the Mayo Clinic, and done a residency there. After that, I would have worked in general practice in Sea Point, which is in Barna, and would have worked at Connacht, which again, back to the weather, would have worked at Connacht Rugby for a couple of years, having also worked in the FAI in international level soccer. And then would have moved down to Munster approximately 6 years ago now to take up the role as head of medical. Along that time, then I would have gone to Bournemouth and to the AEC college, where I would have completed my MSK ultrasound training. I would have been using that since that time in kind of day-to-day practice. Would have initially started using which is a portable HM70, which I would have purchased myself and then use that on a day-to-day basis to kind of upskill and just learn my own trade. And over time, then I've been lucky enough to get access to slightly improved machines since that time, which is just helps with the day-to-day work. So in terms of why use ultrasound, I suppose the first thing is you'll be ease of access. If it's something that you need, it's in your office, we have it right there. It's relatively cheap compared to and it's certainly improved resolution for certain pathologies, particularly for tendon pathologies and things that we've got small field of view. You can get a certain better clarity of diagnosis. Certain things will actually look better on ultrasound than on MRI or X-ray or CT. Sonopalpation is really helpful in terms of when you have someone who sits in front of you with an MRI, and they've got multiple different findings, but actually using the ultrasound to help guide your diagnosis is really helpful while you're sitting there, kind of matching the clinical picture up with the imaging. And really that's the ultimate thing is you're using the imaging as a guide to confirm your diagnosis. You should probably have a fair idea before you pick up the probe what you're looking for. It's really helpful in terms of dynamic assessment, and I'll show an example of that later on in terms of how you can use ultrasound with the patient there and then to kind of confirm what they're feeling and what their pathology is, which over something like MRI or CT, where it's a static image, you can't do that. And then one of the predominant reasons I started with ultrasound was actually to guide my interventions, so that for certain joints like knees and shoulders, it's reasonably okay to do that blind, but once you go on to smaller joints or certain areas, you want to be certain that you're in the area, and using ultrasound in that setting certainly makes that a lot easier, and probably makes the procedure a lot more satisfying for you. And once you get the comfort of using the probe and using the screen, I think it probably becomes just as quick. Certainly in the starting point when you're doing the two, it might slow you down a little, but it will improve your outcome and certainly improve the procedure both for patient and for you. So tendons is probably one of the areas where ultrasound really does show that it's probably as good, if not better, than the other modalities. So a very basic, typical thing is maybe looking at someone presenting with knee pain, and you're concerned about anterior knee pain that came on with activity, fairly acute onset. And this just gives a nice overview of the dynamic nature of ultrasound, how you can use it, the great resolution that you'll see with ultrasound. So what you see just above here is the quadriceps tendon. This is patella. From a proximal, we're going from proximal to distal. And this will just give a nice view of what it's like to use ultrasound on a dynamic situation so that you can kind of sit in front of the patient and they can localize their symptoms. So you can see the quadriceps tendon running over into patellar tendon. It's almost continuous the whole way. And the patella sits more like almost like a sesamoid bone. You have a great view of the patellar tendon, see that nice fibular structure throughout, no gapping, and the fat pad, half a fat pad just below it. As you come on distally into the distal patellar insertion, you just start to see a small little area of cortical irregularity right here at the tendon insertion. And the patient was able to kind of indicate, or player was able to indicate, look, this is where I've got the symptoms, this is where I'm feeling that pain. So right then and there, you have your diagnosis, you have your clarity of picture. You've also been able to kind of have a look at the rest of the tendon very easily. So certainly having access to it right there and then for something like a patellar tendinopathy is really, really helpful, quick, easy. You're not relying on sending someone for an MRI scan in this situation. Again, this is another case of a player presenting with relatively acute onset of knee pain. And this is looking just in a number of settings. So you're looking at patellar tendon here in cross section, and you have this focal area of measuring about 8 millimeters, nearly 9 in diameter, of a hypokelk area with some power Doppler within it. Then you're measuring from the proximal patellar pole distally, and you can see the length is nearly 2 centimeters of hypoechogenicity with, again, some associated acute paradoppler in that kind of mild to moderate range. So you could see here and assess the rest of the tendon, test the tendon both from a dynamic point of view and see that you've got a focal, acute, interstitial, partial thickness patellar tendon tear. Again, fitting with your diagnosis and being able to monitor that then over time to see the response to time and loading and see how that repairs. If it was something where you wanted to guide an intervention in the form of something like a PRP injection, again, you can do that under ultrasound in this setting. So really for tendon pathology, it's hard to beat compared to other modalities. Again, another example of just that inferior patellar tendon of another player, just that proximal patellar tendon pole, where you see this area of hypoechogenicity within the normal fibular tendon structure. Again, seeing it at the insertion with some cortical irregularity. A nice clue for those chronic tendinopathies is that the bone underneath it will look irregular where the enthesis is, and you'll get some calcification with the tendon as well, and you can measure this as well. Another area that we can use this in is obviously the Achilles tendon. And this is a standard Achilles tendinopathy where there's quite a significant thickening of the mid portion of the Achilles tendon, associated with kind of moderate paradoppler, where nearly 50% of the tendon is taken up with neovascularity. So this is a very straightforward, able to show the player, look, you've got chronic mid portion Achilles tendinopathy without any area of actual tendon tearing within the tendon itself. And then you can guide your management based on that. Another option then in terms of tendon or Achilles tendon presentation is player coming again with posterior heel pain. But in this situation, the mid portion of the Achilles tendon looks fairly normal. The thickness when measured was less than 5 centimeters, or sorry, 5 millimeters. And guiding our probe more distally, though, on the insertion of the Achilles, you can see quite a lot of cortical irregularity within the tendon. So there's intertendinous calcification and also some irregularity at the enthesis again. And even just you'll get a small appreciation for where that's extending up into the pre-Achilles bursa. This is it on cross section. So again, you can see multiple areas within the tendon of calcification with some nice evidence of posterior acoustic shadowing where the sound beam can transmit through, which suggests this is very hardened calcification versus where you see tendon, so where the calcification is a little bit softer, you'll see the sound beam transition through. And then again, with the very significant area of neovascularity within the Achilles tendon, again, correlating with the level of symptoms that the player had at the time. And again, this is just the area of that pre-Achilles bursa, which you can see does extend quite close into the tendon. So would make you very hesitant about intervening in terms of injections for risk of any progress into the actual tendon itself. So again, just some nice examples of where ultrasound can be used quite point of care, point of contact, and give clarity of diagnosis relatively quickly. A little bit more tricky and certainly not something I'd rely on ultrasound for, but can be used is up around the proximal hamstring. So another injury we would see commonly in rugby players, particularly from a poach type mechanism, where a player is trying to crouch over a ruck and gets hit from behind and they're forced into hip extension with the knee fully extended. And what you see is that that normal fibular pattern of a tendon loses that fibular pattern. You get hematoma, which is this kind of white cloudy area within where the tendon structure. And then this is on cross section. You'll see this dark hypocoque area where the tendon would normally have sat, right next to the semitendinosus, where you expect to see the tendon of the semimembranosus. And then this is a confirmatory MRI scan showing complete loss and extensive hematoma throughout the posterior thigh with retraction of the semimembranosus tendon back down the thigh. So this is an injury that required surgical repair. And what was helpful on the way was we were able to use ultrasound to monitor progress and healing, to see that there'd been no acute re-injuries, and then use MRI to confirm or not whether that is the case. We've also used ultrasound quite well for direct muscle injury, so contusions, direct muscle injuries. And to give a context, this is an area where in rugby, players will carry a lot with their shoulder and use their shoulder as the contact. So in this situation, player complaining of upper arm pain and swelling. And here you have on the right of, or on the sorry, the left of the screen, the biceps, and just to the left here, the brachialis muscle. And within it, you'll see an area of hypoechogenicity and also just this small outline of hyperechogenicity. This is then transverse. And what you'll get then is you'll see a little bit better once it's outlined, just this area of approximately 1.5 to 2 centimeters of hyperechogenicity within the muscle with posterior acoustic shadowing. So the sound beam not transitioning through. Again, looking at this then on long axis, again, you see it here, this area of hyperechogenicity. You can see the humerus here. You're not able to see it deep to this because this is all hardened calcification within the muscle. So this was consistent with an area of what's called myositis ossificans, where a muscle hematoma has unfortunately converted into bony formation instead of reabsorbing back into muscle and reconstituting into muscle. And these can be left with chronic injuries. And I have a number of examples of this, particularly in rugby players over the upper arm and upper shoulder, where again on MRI this would be quite hard and could be quite indistinct. Versus ultrasound, where you get a much better view. X-ray is helpful as well to confirm the area of bony abnormality. And you can use this then to guide any intervention. One of the common areas I'd actually use ultrasound for is actually in our ankle assessments, particularly players presenting with maybe either lateral ankle sprains or ankle injuries post-match. So this is just this is an example of a player who actually got a direct impact to his mid thigh or mid shin, was complaining of pain and clicking over the lateral aspect of his calf after a game. So just on ultrasound, what you see here is the line in the fibula with some cortical irregularity just coming through here, and again here with this cortical irregularity just in the mid shaft of the fibula, concerning for a fracture. And then here is the X-ray, which showed this straight line right across where you have this almost direct impact and non-displaced fracture right through the mid shaft of the fibula. Player himself then didn't complain of any specific ankle issue. So we looked at his ATFL. So this is the fibula and talus here, and this is the ATFL, which looks reasonably normal with normal fibular pattern. And then further over, then we'd look and see the CFL just underneath the perineal tendons here, where it's rising up along the calcaneofibular region. And we look up at the AITFL, which is the syndesmosis, and you can see just this hypoechoic cleft right through the AITFL. It's quite thickened. And also it's this split line right through it, concerning for a significant syndesmosis injury. So we then would have gone to an MRI to confirm or check this. And certainly on MRI, you see this thickening and loss of the AITFL with the normal ATFL below it. Um, and this was helpful again, why MRI was able to confirm the diagnosis, but ultrasound was able to kind of pick up this finding in a player that was otherwise asymptomatic in that region, but had another injury. So then again, using ultrasound can be helpful, just looking at very simple point of care issues. So one of our staff actually complaining of pain and swelling in the back of his knee. Again, this is in transverse in the posterior knee and the popliteal fossa. You have the medial gastroc here and the semimembranosus tendon. And just between these, you see this hyperechoic area or hypoechoic area that is compressible. So as it's compressible, you know that it's a more liquid rather than solid swelling. There's no hyperechogenicity within it. Important always to check because you'll notice here that the tendon itself also looks hypoechoic, but this is due to anisotropy, which is a common issue in ultrasound that you have to be aware of from a tendon point of view, that if a tendon isn't very perpendicular to the beam, you'll get this almost dark area and you could confuse this with actual liquid or fluid swelling. So important just to be aware of that. So you would have seen that swelling both in transverse and then also in long. So this is going from proximal to distal. That's about a 4 to 5 centimeter in area. And then what was helpful for this is we can guide an intervention and actually aspirate this. And we're able to actually get nearly 50 mils of clear serous fluid with fairly quick resolution of symptoms. And then if you wanted in that situation, then you could follow that by dropping in a small bit of steroid to see if that could just help that to compress down. Now, unfortunately, these can commonly recur, but in this instance, seem to give good relief of symptoms and also settled the issue for him. Again, another player post-traumatic would have landed on his elbow and would have complained of swelling just over the back of his elbow, just over the olecranon. Here you can see this again, hypoechoic area that was compressible, and you have to almost apply very low pressure to the area and almost use a gel standoff because these can collapse quite easily. And you can measure this. Again, you see a small area of paradoppler. Now, in things like an olecranon bursa or a prepatellar bursa, they're things that I've probably avoid intervening due to the risk of infection, and also commonly they'll recur after you drain them. And occasionally, even if you can develop these chronic sinuses, should you put a needle into that and it doesn't settle. So in that instance, we were able to look at it, compress it, and it settled of its own accord, and we didn't have to intervene. Another example was just a player who presented with some hand pain post a tackle session. And this is just scanning over his third metacarpal. And you can see the cortical irregularity with a step here and some early hematoma formation. So it's concerning for a fracture of one of his metacarpal bones. And we were able to confirm that on X-ray, which shows a spiral fracture, non-displaced of his third metacarpal. Again, this was managed conservatively, but the ultrasound was able to help us provide a kind of an initial point of care diagnosis. So then just where sometimes the imaging doesn't fit with the clinical picture. So this player was this person was referred to me with hip pain and groin pain. I had an MRI scan, which was reported as showing some pubic symphysis bone marrow edema and adductor tendinopathy. But really, in reality, the history from the individual was that he was getting a clicking and clunking sensation over his hip. And so on point care ultrasound, we were able to look at this a little bit more closely and try and actually correlate what he was feeling. So this is, to give context, a transverse ultrasound sitting over his pectineal eminence that's just superior to the hip joint. This is his iliopsoas tendon. This is the iliacus muscle just sitting above it. And what we're watching for is the tendon here, just over the pectineal eminence. Just here's the iliopsoas tendon with the iliacs muscle. And just here you see a slide of muscle underneath it and then a sudden clunk, which was reproductive of his symptoms. So this is consistent with the snapping iliopsoas tendon, and was able to give this individual a diagnosis there and then, which, despite an MRI report, was actually consistent with his actual presentation. So certainly ultrasound, I find, is very helpful in terms of being able to provide a kind of a point of care access. It helps in terms of interventions. there's a number of different areas where it probably almost provides better diagnosis than MRI. But as I would say, kind of describing ultrasound, I'd use it as something that can be quite specific if I'm looking at a very specific question, but isn't always sensitive. So occasionally you'll have to revert to MRI if your question hasn't been answered, or to confirm the suspicion, particularly in maybe higher grade injuries. The European Society of Skeletal Radiology would have certain guidelines where they'd be able to grade recommendations based on the pathology and area where ultrasound would be equivocal or better, depending on the pathology that you're looking at compared to other modalities. So it's a very good reference to look at in terms of where you may use ultrasound, or you may decide that in certain situations that there's better modalities available. So certainly ultrasound definitely plays a very important role for both our diagnosis, and also in terms of the interventions that we can perform from a point of care access. So, Jamie, I'm not sure if you have any questions at this stage that you'd like to go through, or any other information that you might require.
Yeah, sure. Yeah. Well, firstly, thanks a lot, Jamie. It was a great presentation. Really interesting to hear how you're using ultrasound in your clinical practice. And yeah, we've got some pre-submitted questions. So we'll start with those. And if you haven't already done so, if you're watching this webinar, you can use the Q&A tab at the bottom to submit any live questions. So the first question we have is, at an elite sports level, is it always safer and more sensible to get an MRI scan rather than rely on an ultrasound scan?
So again, it depends on the pathology. So for certain things, for example, like a proximal hamstring injury or a hamstring muscle injury, standardized imaging, and it can be shared amongst lots of people. For certain things, though, where we've had certain injuries, and I might actually share, it was meant to be in that presentation, so I'll just share a couple of slides on where ultrasound actually probably provides better diagnosis. So something like a medial gastroc injury, I think ultrasound actually is probably better than MRI. And again, certain tendon pathologies or things like myositis certainly show up, or calcifications show up a lot better on ultrasound than on MRI.
Yeah, no, that's interesting to know. And I think, as you mentioned, ultrasound can be, more useful than MRI for a lot of pathologies. Next question we have is, what is the role of elastography in MSK ultrasound and its potential benefits in the MSK application?
So certainly it's an area that's used a bit in terms of tendon healing and tendon response to intervention. On my original machine that I would have had available to me, it wasn't really preset. So you have to have certain settings on the machine, or it comes with a package. Newer machines that I have now has it available, but it's not something I've used frequently enough for me to be comfortable confidently saying, yeah, I can see a difference here. But certainly the role is increasing, and the standardization of machines certainly, and how you would use it is definitely increasing, but it isn't something I've been using a lot in my practice just yet.
No, I think it's a growing area, isn't it, of MSK
Yeah, and
ultrasound?
certainly it makes a lot of sense from a kind of a theoretical point of view, that really what you're trying to, particularly in tendon pathologies, you're looking for that tendon stiffness to improve, and that's what it's essentially measuring. But it's just the standardization across different machines is different because it's a different package, and again, it's something that you probably need someone to guide you through first before you start comfortably using it, I think.
Yeah, yeah. Next question. Um, how often are you using diagnostic ultrasound in your clinical practice? Do you use that on every patient, every case, every opportunity?
I would definitely use it daily, and it depends on the case. A lot of the time, I'll use it quite frequently. A lot of the time, what I find is, as I say, I kind of mentioned this earlier, is that sometimes helps to localize symptoms where it's not quite clear. Particularly things like ankle or in around the hip and groin, it can be really helpful. Um, you find with foot pathology, lots of things will come up on an MRI, and trying to decide what's the actual relevant issue on the MRI for the patient. The ultrasound can help in terms of what you call sonopalpation, or just localizing the symptoms, and the person's able to go, yeah, that actually correlates with where I'm feeling most of my pain, and you can then safely kind of suggest or disregard some of the changes in the MRI as incidental findings, whereas then you can guide your treatment based on the use of the ultrasound. So definitely from that point of view, I find it very helpful. Probably use it daily, not every single case, but definitely a high percentage of cases I probably go to it. Yeah.
Yeah. And do you use pre-season ultrasound screening? So do the players, would you use ultrasound in sort of the common injury areas just to assess
Yeah.
sort of how they're looking or
So the research on this is a bit mixed, because it doesn't always translate that the people who have maybe predefined Achilles or patellar tendinopathy will be the ones who then go on and develop the symptoms. And I think the just in terms of the time load, if we have a squad of 45 senior players and another 15 academy players, you got to decide first of all, well, how often do we see Achilles or patellar tendinopathy, and then do I have the time to scan bilaterally 60 individuals, which is 120 scans in an already busy preseason? And will it
yeah,
change my management? Am I going to suddenly turn around and say I'm not going to do X, Y, and Z with this player? So I'm not sure the benefit, because the research is mixed. I could certainly look in an ideal world, if I had the time, I'd love to do it. But I'm not sure would it actually make a huge difference. I know certainly in Leinster, Kevin Cronin, who's a ultrasonographer in UCD, would have done a bit of look around the pronation angle for hamstrings, and looking to see can they make a difference there, and would that correlate with hamstrings. So that's some interesting research. And again, if you've got someone who's got the time and dedication to do that quickly, great. I'm a sole practitioner on my own in the club, so it's very hard to do that probably.
yeah, and that's interesting to hear. You know, if you've got a squad that size, it's probably not feasible, is it, to start scanning everyone on multiple areas. Otherwise, you'd be scanning well into the season, I think,
Yeah,
Jamie.
and I think it's got to be something that you're going to see. You see, it's got to be a problem first. Do we see lots of Achilles or patellar tendon problems? And then if we do see lots of them, are we going to modify the program based on the findings? So there's got to be a reason to do it, And we probably don't see a huge amount of Achilles and patellar tendon problems, and we're probably not going to modify a lot individually based on that. But certainly we'd use it on an individual basis for certain people. Yeah.
Yeah. And next question, how would you differentiate between a ligament sprain and a ligament tear on ultrasound?
Yeah, so I suppose it's the nuance, but in essence, a sprain is where the what you'd see on ultrasound is that the ligament in question will probably be thicker, it'll be darker, so more hypoechoic, but will still have continuity. Whereas with a tear, you'll see kind of like that the example I showed the ankle, you'll see that kind of almost cleft between where the fibular pattern should see. And dynamically, you can look at that, particularly in around, say, the ATFL or up around your ulnar collateral ligament. You can see that on dynamic ultrasound that starts to separate apart, particularly when you put that either a valgus stress in the elbow or an inversion stress at the ankle. You can see that separation even more clearly, or fluid even tracking between the ligaments, which suggests discontinuity.
Yeah. So that separation is
Yeah,
key.
which you don't see on MRIs. It's a static image.
Yeah. So that's where ultrasound is obviously,
It
maybe a
can
little
just
bit
provide a
more.
little bit more detail. Yeah, yeah.
Yeah. Yeah. Next one, how do you adjust ultrasound settings, e.g., gain, depth, frequency when evaluating deep structures such as a hip joint, especially in larger athletes like rugby players?
So I think the first thing is depending on where you're looking is knowing which probe to pick up first of
Yeah.
all. If you're
Yeah.
going for something deep like a hip, particularly if it's a hip intervention, I would almost go to curvilinear first.
Yeah. So
Depending
you want a low frequency
You want a
curvilinear.
lower frequency to get that deeper structures, because what you'll find is if you try and adjust the depth on the higher frequency probes, it's actually just not as clear. Whereas when you switch over to that curvilinear, you just get a much clearer picture. And then what I'd always kind of say is start with a greater depth than you think you need and then adjust back up. Otherwise, what happens is you stick on and you're not quite sure where you are and you end up having to drop down, down, depth, 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 depth. And then you can get a picture. So almost start deeper and adjust up if you want to get closer resolution, if that makes sense.
Yeah.
And then just having ability to just change your focus depending on the depth, the structure you're looking at. the gain is straightforward enough in terms of, again, what you're looking at and trying to change. You'll find, depending on the athlete, thankfully for us with our cohort, generally speaking, because there's a lot of muscle, it tends to conduct the sound really well. So you get a lovely resolution of images. Whereas in, say, general population and certain groups, if there's less muscle and there's more fatty tissue, it becomes a lot harder. And that's where you're almost better going lower frequency because you just don't get the penetration. Um, so again, that's probably just knowing your cohort of athletes or people or patients, and be able to adjust based on that probably makes the biggest difference. So start wide and narrow back in, I think, is your better way to go.
Yeah, and I imagine as well if you don't have access to a curvilinear probe, maybe know your limitations as well of what the system can do.
Yeah, and again, in that situation, like using something like a trapezoidal view is quite helpful. You
Yeah.
get a wider field of view. So yeah, I think if you think you're starting deep, go with it, and then you can always change over if you want to go more superficial or get high resolution, absolutely. But I think choosing your probe first and then actually starting deeper and wider and then narrowing your angle back in is probably the better way to go.
Yeah. And we've got one question on the live Q&A feed as well. So this one is, what are your thoughts on the use of ultrasound referrals from a primary care setting? Would we be delaying input for the patient when we could refer them on?
Not Sorry, I'm not sure exactly what you mean by that. Is it
Yeah,
should we be using ultrasound
I'm not
or
entirely sure of the context. I'm just interpreting it as perhaps should ultrasound be used within the primary care setting, or would we be delaying? Um, if it's not used at primary care, are we delaying the treatment pathway by having to wait for a scan within a triage center or secondary care?
yeah. I think it depends. Again, it's why are you using the modality, I think is the question.
Yeah,
So if you're using it because of like using it in the correct setting, so knowing what ultrasound is good at, and can it answer the question for you, or you'll get questions sometimes. You go, well, look, I can't answer this question with an ultrasound. It's not, you're better off getting an MRI in this situation. So I think it depends. So sometimes it can be really helpful. Like give an example, an atraumatic shoulder pain coming in where someone hasn't fallen, getting an X-ray first to make sure there's nothing, arthritic in the joint, and then an ultrasound can answer the question just as well as an MRI, and you're not spending, potentially 6, 7 months waiting for MRI that you can answer on ultrasound. So in that setting, I think primary care wise, it could be really helpful. Versus if you're sending someone who's got knee pain for an ultrasound and it's not a patellar tendon problem, it's probably going to be not going to be of huge benefit in that setting. So it's just matching why you're doing it, probably again what you're using it for. But a lot of stuff can be answered with it, or in combination with X-ray. Using the two smartly to answer the question you have probably is we've become a little bit over reliant on MRI for certain things.
yeah. So it would be handy to have access to it in
Yeah,
primary care, but it's not used on all of probably the more common MSK conditions that are seen in primary care, I
I
imagine.
think, as I say, I think it's just knowing what you're using it for. Yeah, if that makes
Yeah,
sense.
yeah. Yep. Okay, well, thank you everyone for joining us this afternoon. And obviously, a massive thanks to you, Jamie, for presenting for us. It was a really good presentation, and we appreciate your time and expertise. So, following this webinar, everyone will receive a link to the recording. Um, for those who couldn't make it live as well, you will receive that. And if you want to get in touch with us, if you have any further questions or just you want to look into using ultrasound within your practice, and you're looking for support and ways you can get into that, my colleague Katie will follow up this webinar, and send an email out to yourselves with my contact details on there so you can get in touch by phone or by email. And we're really keen to support you and your training in ultrasound. So thanks again for joining us, and enjoy the rest of your day and look out for our next webinar here at PhysiQuip. Thanks again, Jamie.
No problem. You're welcome.
Okay, cheers. Take care, everyone. Bye.